Well, thank you once again, Dr. Wisanji, for the introduction. And hi, everyone. My name is Soukaina. I'm a third-year medical student at McGill University. And as mentioned by Dr. Wisanji, I've been conducting a research project over the summer. So with Dr. Wisanji, Dr. Esli Osman-Liu, and Dr. Nadia Safa, Dr. Alia Noor Mohammed, as well as with the help of Elena here present. And the research project was about improving perioperative care for Northern Quebec pediatric surgical population. So without further ado, I'll just start with a quick introduction. So as we may know, there's a lot of Indigenous communities that are living in rural area and that continue to face discrepancies in healthcare access. To access healthcare, basically, a lot of them have to go through medical relocation, which are quite disruptive for families and contribute sometimes to financial hardship, loneliness, emotional stress, as well as elevated anxiety and fear. And so the two rural areas we were really interested by were Nunavik and Terre-Cree de la Baie James, which are two rural areas which the population is mainly comprised of individuals from Indigenous descent. So every year, children from these regions and their accompanying family are displaced when requiring general and thoracic surgical care to have it here in Montreal at the MCH. So we were interested in the model of care that these patients have to go through, and we saw that these patients have to go through multiple steps before they can go back home. And this includes the initial surgical consult, which in most cases is done in person. Then they go through the surgery and then their discharge. And after that, they have a first follow-up appointment, which in the Harvey E. Beardmore Division of Pediatric Surgery at the MCH, there's currently a policy that says that that first follow-up appointment has to be around 1 week to 7 days of duration after the discharge. And then in some certain cases, some rare cases, they'll have a second follow-up appointment if needed, if there's a complication detected in the first follow-up appointment. So we were interested in analyzing three aspects. So the first one were the complication at the post-op follow-up. So some of the question we asked ourselves was, what is the incidence of complication among Northern children that underwent general surgery and that are detected at this first follow-up appointments? We were also interested by what are these type of complication and whether they really require tertiary care. As well, we were interested to study if there's any parameter that can predict the occurrence of these complications. The second aspect we were also interested to study was the time in Montreal that these patients have to spend when having their surgery. And so we were interested to know what's the average time the family spend in Montreal due to medical relocalization, as well as which time frame, so from 1 to 4, can be optimized and how it can be optimized. And lastly, this is a new aspect that we are interested in studying more recently, which is the modality of encounter, and studying whether telemedicine can be used as an alternative modality of encounter, and if there are available resources up north that can permit the offer of this option. So how we did this is basically we conducted a single center retrospective chart review looking at the perioperative management of children from Nunavik and Terre-Cree de la Baie James who underwent general or thoracic surgery intervention at the MCH, including children less than 18-year-old. And when we started, basically, we started with a huge list from the MCH operative room booking software Opera, which that is detected between January 1st and December 31st, 2020. And we saw that there was 3,889 surgeries. From these surgeries, we really selected only the patient that had a residential zip code in Nunavik and Terre-Cree de la Baie James, ended up with 485 surgeries. And then we really selected the patient that we can really that can be sent home safely. So to do that, we established some exclusion criteria. And these exclusion criteria include surgical management that require multidisciplinary care or a second surgery unrelated to the initial procedure. It also includes if there's a kid that had one or multiple concomitant comorbidities requiring a comprehensive multidisciplinary management, or if there's any complex surgical presentation requiring prolonged stay and or multiple follow-ups, so more than 3. So in all these cases, it would be unsafe to send these children back home. And so we can't really talk about improving the time in Montreal for these patients, and that's why we excluded them. So we ended up at the end with a cohort of 281 patients from Northern Quebec, which we studied different parameters that we'll discuss right now. So first of all, we noticed that more than 50% of these patients came in Montreal for acute appendicitis. So we see here 52% of our cohort is that. The other is other diagnosis that we see here, but I'll just drive your attention around this information right here. And we'll discuss later a subgroup analysis that we did because we have this significant amount of acute appendicitis. But before doing that, we'll just go through the main finding of the research. So first thing first is you can notice right here that the amount of complication detected at the post-op follow-up is very, very low. So it's 4 complications that were detected at the post-op follow-up. Which was our initial question. So how many complications are detected at the post-op follow-up? Secondly, we see here that the number of complications detected at the post-op follow-up, there's none for elective surgeries. And we see right here as well that we try to study if there's any predictors for these complications. And we see for the p-values that we have right here that none of these really had a significant, enough significant statistical significance to say that there are predictors for these complications, and as well because we only have 4 patients that have complication. And lastly, I just want to drive your attention toward time 3, which I'll remind you is the time between discharge and the first follow-up appointment. And we see right here that it's quite similar between the cohort of patients that didn't have any complication versus the one that had complication at the post-op follow-up. Meaning that really we're keeping many children in Montreal after their discharge when there's no reason to keep them. So moving forward, we concentrated on the complication that we identified. So the 4 complications that we identified, what were the diagnosis? Mostly it was acute appendicitis. One of these acute appendicitis was a perforated appendicitis, which was a grade 2 perforated appendicitis. And we also focused on what are the management for these complications. So we using the Clavien-Dindo classification, we see that 3 out of 4 of these complications require medical management, while only 1 required a ERCP. And so I mentioned earlier that a lot of our patients had acute appendicitis, and so we did a subgroup analysis that we can see right here, again to identify if there's any predictors for complication in this cohort of patients. And we see again there's no enough statistical significance that allowed us to really pinpoint some predictor factors for complications. And last but not least, we also studied the different time frames. So we see right here that really the 2 times that are the most important in this model of care is time 1 and time 3. So time 1 for elective surgery in particular, because that's when we have time between the initial surgical consult and surgery. For emergent surgery, we don't really have, time 1 don't really exist. And we identified that some patient had an extended time 1 or a time 1 that was more than 4 days, so elective surgeries that was scheduled not in the same week. And those patients, we saw that 11 of these patients, it was the case for 11 of these patients. In 4% of these patients, it was explained by a patient's factor, so something that we can't really have control over, while for 16% of these patients, it was unexplained by patient factor and could potentially be improved for these patients, for example. And then time 3, again, which is the time between discharge and the first follow-up appointment, we see that there isn't that much difference between elective and emergent surgery. And again, that this is the time that could potentially as well be improved since before we saw that there isn't as well a difference between complication versus no complication. So to summarize some of the main findings of the study, so regarding complication detected at the post-op follow-up, we saw that only 1% of children that underwent general surgery at the MCH from 2011 to 2020 had complication identified at the post-op follow-up, and 3 out of 4 of these complications required medical management, while 1 required ERCP. For the time in Montreal, we saw that the time from discharge to post-op, so time 3, is similar from a patient with complication versus no complication detected. And we saw as well that 16% of patients waited more than 4 days after initial consult for elective surgery. So in conclusion, we see that the 2 times that you can really improve is time 1 for elective surgery, as well as time 3, which can be optimized by exploring non-presential options. So all of this really pinpoint to one thing, is the need to reassess recommendation and management options suggested to families when they receive surgical care at the MCH. So just to go back to our model of care. So the question we ask ourselves at the end is, what does the future model of care look like for these patients? And so it can look like, really how it will look like will depend not only on the findings of the study, but also on the perception of these patients, their perception of this model of care. So, which is something we want to add an input in our study, is really what would be better for them. But for now, what we saw from the findings, that for time one, it can be improved for elective surgeries by making sure that the surgery is scheduled within the same week, so we can reduce that time. And for time 3, we saw that elective surgery, there is no complications, so we could potentially suggest non-presential follow-up. And for emergency surgeries, which we saw had some complication, we could have 2 options, like have presential follow-ups when needed. And these non-presential options can also be introduced potentially at the stage of initial surgical consult, as well as if there is a second follow-up need that we need after that. And I just want to mention as well that there's a process mapping at the hospital level in discussion with Dr. Puli Gandla that can also help with this mapping this model of care. So last but not least, I just want to mention the OCAP principle, which are principles that are really important ethical principles to introduce or to have when we're doing research with Indigenous population. And these OCAP principles really put forward the benefit and the need of Indigenous communities, and to ensure that when we're doing research, we're really prioritizing that over everything. So really the whole study, all the results that we're having right here are not meant to be prescriptive, but rather to empower Northern population in choosing healthcare delivery model that best fit their needs and their benefits. And ultimately, we want to be able to generate a framework that will permit shared decision with the Northern population, and to really improve the assessment, whether it be from the initial surgical consult until they can go back home. So that's pretty much it. And so the next step for us is really ensure that we have the perception of these communities, like whether it be from the current model of care, as well as the introduction of other options that we mentioned earlier. So whether it be non-presential options like telemedicine or phone follow-up, etc. So that's pretty much it. Thank you so much for your attention. And if there's any question, I'm more than happy to answer them.
Okay, excellent. Good afternoon, everyone. I hope you're doing well. My name is Shadi. As Dr. Wisanji mentioned, I'm a second-year medical student here at McGill, and I'd like to thank you for the opportunity to present the work I've been carrying out as part of the Summer Research Bursary Program. Today, I'll be presenting the research protocol to a study titled Evaluating Socio-Demographic Factors Influencing Pediatric Surgical Care in Canada. My supervisor for this project is indeed Dr. Hussein Wisanji, and our project coordinator is Elena, whom I'd like to thank for past and ongoing guidance with this project. Dr. Aliyah Nur Mohammed from the Department of Anesthesiology will provide her relevant expertise as well as guidance for this project. And lastly, Drs. Guy Lacroix as well as Maud Laberge from the Department of Economics and Business Administration at Université Laval will provide expertise for the health economics aspects of this project. So it's well established that non-clinical factors do matter in surgical care. Factors such as socioeconomic status, geography, race or ethnicity, or characteristics of the providers who provide surgical care, such as the surgeon or the anesthesiologist involved. We know that those influence access to surgery, surgical outcomes, as well as costs. Now, if we want to identify and minimize the impact of these disparities in care, we need an accurate benchmark of the field. After all, it's hard to reach a destination if you don't know where you are. What we do know is that dressing such portraits in the United States has fueled an abundance of impactful research in pediatric surgical services. Here's such a study published in the Journal of Pediatrics in 2013 that describes the demographics of pediatric surgery, hospital type, surgical procedures, and quantity of inpatient pediatric surgery in the US. And the implications of these types of studies are extensive. whether we want to describe practice patterns for specific surgeries, whether we want to identify disparities in outcomes, or whether we want to look at the factors that might underlie these disparities. We can do a lot here with these benchmark studies. Yet, to our knowledge, no such benchmark exists for pediatric surgery in Canada. And in the context of Canada's publicly funded healthcare system, with limited resources, such a study would be an important step in determining where to concentrate our resources in order to achieve equity in pediatric surgery. So the research question for this study is, what's the current landscape of pediatric surgery in Canada, and what are the determinants of outcomes and costs in the delivery of pediatric surgical care? And by landscape here, I mean that we're interested in identifying the most frequently performed operations on children in Canada across all provincial jurisdictions and surgical specialties. We want to identify the socio-demographic, economic, geographical, hospital, and surgeon level factors that are associated with disparities in outcomes and costs. And lastly, we want to compare the delivery of pediatric surgical care between Canadian and American settings. So the study will be a retrospective cohort study using national health administrative databases. Our participants will be individuals aged 17 years or younger from all Canadian provinces who underwent either inpatient or outpatient surgery from January 1st, 2015 to December 31st, 2019. And so this will be a 5-year outlook. Our exclusion criteria will be missing socio-demographic information due to patient linkage issues. And our data sources will be 4 databases available through the Canadian Institute for Health Information, or CIHI, namely the Discharge Abstract Database, or DAD, which collects inpatient surgery data across Canada, except for Quebec, as well as day surgery data for some provinces. But the main day surgery database is the National Ambulatory Care Reporting Service, or NACRS. And then these 2 databases here, the Canadian Management Information Database and Canadian Patient Cost Database, are financial databases, and they provide costed hospital encounters, although with different approaches. For the province of Quebec, because we want to include the province in our benchmark, we will use the Maintenance et Exploitation des données pour l'étude de la clientèle hospitalière, or MEDECO database, which is provided for by the Ministre de la Santé et des Services Sociaux du Québec, or MSSS. So the data that we'll be collecting from these databases are the following. Some of you might know in this call that CIHI doesn't routinely collect sociodemographic data. So we'll be gathering these variables by linking a patient's postal code to these following measures gathered by Statistics Canada as part of Census Canada. And so we have sex, ethnicity, whether they're part of a visible minority or not. Immigrant tercile here refers to a measure developed by Statistics Canada that represents the concentration of immigrants in the neighborhoods surrounding the patient. Rurality, whether we're looking at rural individuals living in rural locations, semi-urban or urban centers, distance from treating hospitals. Material and social deprivation is a deprivation index that's developed by the INSPQ. And really what it is a measure of socioeconomic status, but it's actually more valid than just looking at household income or neighborhood income. And really, why is that the case? Because it's a multidimensional view of the socioeconomic characteristics that affect a person's life. Hospital setting, we'll be differentiating children's hospitals from hospitals other than children's hospitals. And lastly, hospitals with trained pediatric practitioners. What do we mean here? Well, surgeons who practice in children's hospitals will be assigned a unique identifier. And then wherever those surgeons practice, we'll be designating those hospitals as hospitals with trained pediatric practitioners. And you might ask yourself, why are we adding this category? Well, the rationale here is that trained pediatric practitioners may influence clinical care and outcomes. Lastly, surgeon specialty and volume. We'll be looking at general surgery versus pediatric surgery. Volume, low versus high. Procedure subspecialty will be categorizing the specific interventions that we're interested in into broad categories such as neurosurgery, ophthalmology, general surgery, orthopedics, and more. Now, our outcomes of interest for this study. The goal for a clinical outcome is not only to look for specific surgical outcomes. We're rather interested in an outcome that'll be relevant to a population here that spans across pathologies and interventions, because we're interested in all surgeries, inpatient or outpatient. And so we felt as though all-cause morbidity, as listed here, would be more representative for our research question. And so what's this outcome? It's a binary composite outcome determined externally by the CAI and consists of any documented complication during admission that extends length of stay by at least 24 hours or required a second unplanned procedure. Notably, this outcome has been previously validated and is the most comprehensively clinically relevant outcome within the CAI databases. Now, in addition to morbidity, for each of the most common surgical procedures we'll be identifying, we'll be looking at the cost of an episode of care using aggregate or top-down costing methods. Now, this will include the cost of index admission, the cost of 30-day postoperative ER visits and or readmissions, and the cost of perioperative complications related to surgery or anesthesia. Here's our sample size estimate based on previous study in the US setting. 267,261 patient encounters is our sample size estimate. And the approximate annual operative caseload, that's the number of patient encounters that we have here in Canada per year, is about 71,941. So if we divide big N by small n, we have 3.72 years, and we rounded this up to 5 years. And so this calculation determined the chosen period of study that I mentioned earlier. And the full calculation for this sample size estimate is in the appendix of this presentation. Now, for our analysis, we'll be performing descriptive statistics for those most common surgeries and their associated clinical and demographic informations. And for our prognostic factors that I mentioned, as well as their potential associations with our outcomes of interest, we'll be performing regression analyses. For all-cause morbidity, because it's a binary yes or no outcome, we'll be performing univariate mixed effects logistic regression. And for the cost of an episode of care, because it's a continuous variable, we'll be performing standard linear regression. Now, for factors in which we do find a significant association, we'll be performing a multivariate analysis to adjust for potential confounders such as emergent or urgent presentations, hospital setting, and patient preoperative comorbidities. And lastly, we'll be performing a comparison of pediatric surgery practices between a Canadian and American cohort. Data from the American cohort will be acquired by collaborating with a partner American academic institution. We'll be using descriptive statistics and measures of statistical comparisons between these two cohorts using appropriate statistical tests. Here's the estimated timeline for the study. So as part of the summer research bursary period, I performed a literature review as well as writing of the protocol. In the last few weeks, we've been busy writing data access applications for the CAI and Medico banks, which is actually quite a lengthy process. And then we're finalizing details for the REB approval for this project. And so all in all, it looks like there's going to be about 18 months before we receive access to the data that we're interested in. And this puts us at about mid-2023 for the estimated start date for the study. And then last but not least, the long-term vision for this study. We don't want to have another study that shows disparities in care. So upfront, we're partnering with knowledge users such as the Royal College or the Fédération Médicale des Spécialistes du Québec to address the uncovered gaps in care. And how we'll do that could be by continuous medical education, dissemination of best practices and protocols, or by patient and family education. This is the commitment that we're making for the long-term vision of this project. Thank you. And if you have any questions, I'll be happy to answer them.